Irene Thomas, Cherry Roy, Sarika, Krishna Kakkar, or anybody else. But at
So
least
we can
these
ask
seven. Yeah.
Vinod to just unmute them so that they can participate in the discussion.
Okay, Vinod. Vinod.
So if you can just tell me the names, I'll unmute them.
You can do that. So, Anushka, unmute these candidates. All right, they're doing it.
Okay. So meanwhile, Sandeep, can you just tell us when you said that it is not reaching midline, what are the features we would like to know before planning the treatment?
Sir, first I will investigations to confirm my diagnosis, sir. First I will do, and next I will.
No. I don't want your diagnosis. I want you to tell me about the examination.
Yes, sir.
As Sir was mentioning, we have to go through the different lesions, and we want to bring out what characteristic features we would like to evaluate, which will help us in treatment planning.
First is induration, sir. Induration. I want to see the induration, sir.
Right. What do you want to see? Is this a classic lateral border tongue lesion?
Yes, sir. It is a lateral border, classical lateral border tongue lesion, sir.
But it is very anteriorly placed. The classic one is right in the middle of the tongue and in the oral part of the tongue. So this is little tricky because it is coming very anterior. So what are the other features we would like to evaluate?
Firstly, I want to see for the what is the surrounding induration, sir.
Yes.
Whether it is reaching, whether it is crossing the midline or not. I want to check the induration is whether it is crossing the midline or not.
Right. So what does that mean? What does that tell you? When you say that it is crossing midline or induration is reaching midline?
Yes, sir. If induration is reaching the midline, I have to be very careful in seeing, because there will be a metastasis to the opposite neck also.
Let's look at the primary site. So when you have lesions which are reaching the midline or involving the tip, we will be resecting part of the tip, and which will place a lot of emphasis on how we are going to rehabilitate the patient. Second is your metastasis potential. So you know that when the lesion is on one side, it is usually spread to the ipsilateral neck nodes. When it crosses midline, it might involve the contralateral neck nodes as well. So it's very important, like you mentioned, that the induration is reaching midline or crossing it. That's right. What else?
Next, I want to see whether it is a lesion is involving the floor of the mouth or not, sir.
So from the dorsum as it goes ventrally.
Yes, sir.
So from the lateral border, as it's going ventrally, it comes onto the floor. Show the earlier picture. So this was very nicely showing that the lesion was on the lateral border, involving mostly the dorsum, not involving the floor. So this is very important to describe. As Sir said, when you are describing, I should be able to know exactly what you're trying to tell me. So this lesion was involving the lateral border of the tongue, not crossing midline, and not involving the floor of the mouth. The mobility of the tongue is maintained. So what does that tell you clinically?
Clinically, the intrinsic muscles are not involved and hypoglossal nerve is not involved, sir.
It tells you that the floor of the mouth muscles, that is the mylohyoid and the geniohyoid, those are not involved. So you know that technically you can do a per oral resection and you may not enter the neck when you're doing that resection. So this is very important to document, so because then it might change the way you plan the treatment for this patient. Okay, what else?
And I want to know whether his lesion is reaching the posterior one third at the base of the tongue or not, sir?
Right. So we discuss anterior, we discuss crossing, and we discuss inferior. Now you're talking about the posterior extent, so the amount of the lesion reaching the base of the tongue. So that also has implications on how much you're going to resect. That's right. Finally, what else is significant in this patient? You said that he doesn't have sharp teeth.
Yes, sir.
But what about his mouth opening?
He has mild grade 1 trismus, sir.
Right. So he has trismus. So that also has an implication when the lesion is going posteriorly, because the way you access this will be affected as you're going posteriorly and inferiorly. So it's very important to document all this when you are writing down your examination findings. And it is also important in our patients who have submucous fibrosis, because when you have submucous fibrosis, not only the buccal mucosa and the gingiva, even the tongue mucosa can get affected. So that has a major implication on what type of reconstruction you might consider. Okay. Do we have the imaging findings for this patient?
As it is a T1 lesion, we have not done MRI, sir.
Okay.
Has Dr. Karthik joined? Is Dr. Karthik, has he joined?
Yeah, I've joined in.
So Karthik, I want to ask you, would you recommend an MRI for a T1 lesion like this?
Ideally not. If it's a T1 lesion, you would not do a kind of an imaging at all, probably in this case.
Prathamesh, do you all do MRI for such early lesions?
No, we are not doing for such early lesions. But in case we are having a restricted mouth opening and all, we would have considered.
Yeah. So I specifically asked this question because recently, last week, we were doing a glossectomy for an early lesion like this, and he came with an MRI, and lo and behold, the MRI reported a skip lesion at the lingual pedicle, a skip lesion at the lingual pedicle. So Dr. Kannan immediately came and mentioned that to me, that what shall we do about it? But we searched and searched and there was no lesion there. We couldn't find at the lingual pedicle, and we borrowed it a little further, but we couldn't find it. So I was just wondering whether it is a routine practice to do MRI for such early lesions. So I'm glad that neither of you do it. And today I met Dr. Karthik and he told me MRI costs 8,500 and with contrast 10,000. So certainly we don't do it. Okay.
So there is also some concern about lymph node metastasis, and patients having lymph node metastasis, you would want an imaging. So I think it's a very tricky question when the postgraduations are asked whether you do an MRI for this lesion. So if they find an indeterminate appearing node in the neck, or there is restricted mouth opening, then maybe they can be more confident in asking for an imaging.
So that brings us to another question that we should ask the postgraduates. How would you manage the neck in this patient?
Right.
How would you manage the neck in this T1 lateral border tongue cancer? Who's going to answer this question? Trishna, are you there, Trishna? Sarika? Anushka? I don't know how to get around to this, Prathamesh.
Maybe we need some volunteers. Maybe the ones who are exam going can actually participate.
These are
because
the
it will help them in the discussion.
These are the exam going students that I have the names of. But I think anybody can answer. Anyone among, yeah, somebody is writing down. Vinayak is saying that we'll do a
Vinayak,
selective.
yes, he can unmute and speak. Vinayak?
Yes, sir. Hello.
Yeah, go ahead.
Oh yeah. Not.
So two of the students have answered that they would do a selective neck dissection because this is a clinically and radiologically N0 neck.
So we. Hello.
Yes.
Yeah. So we would go with a selective supraomoid neck dissection. So in this case, preferably, sir, micrometastasis would be there in most of the cases. So in that case, it would be better if primary is treated surgically. Then we would like to go with surgical neck dissection. That's my point, sir.
You said most of the cases means what percentage of cases in a T1 lesion like this will have the micrometastasis into the neck?
I'm not sure, sir.
So here we have Khandelwal who's replied something. Prathamesh, can you read that?
So Kirti has written that if there are no nodes and not reaching midline, then elective neck dissection in less than 5 millimeter depth of infiltration, not indicated for T1 lesion. So Kirti feels that if there is no neck node and the lesion doesn't reach midline and it is less than 5 millimeters thick, then there is no indication for neck dissection.
Okay.
So I think the message the residents should take home is that there has been a debate for last 4-5 decades whether or not to do a neck dissection, and there have been a couple of randomized trials which have actually shown that there is a survival benefit if you do a selective neck dissection in a N0 neck. So when we are looking at T1, T2 tongue cancers, or maybe for that matter oral cancers, there is little doubt that almost 30% of patients will have occult metastasis to the neck. And when they manifest disease, you'll end up doing a lot more. You'll end up doing a larger neck dissection, and you will end up giving adjuvant therapy. And in most patients, you might have a failure following adjuvant therapy as well. So it would be a better idea to contain these diseases in an occult stage. Of course, in almost 70%, you would do an over treatment, but to save one patient, you would need to do 8 neck dissections. So that's been our experience in the elective neck dissection trial, which was published in the NEJM from Tata Hospital. And subsequently from UK, there has been another study which looked at the lesions which depth of infiltration less than 3 millimeters. And even in those, they showed that there was a benefit in doing neck dissections. So what transpires is that early oral cancers, especially the tongue cancers, are vicious and they may harbor occult metastasis, and it will be an opportune moment to do a neck dissection when you're doing the per-oral resections.
This I think is very important. This message must be taken by the student. We in real practice, if we can feel the lesion as a thick lesion, then it is safer to do the neck dissection. It is not always that if you have very good follow-up and you follow up every 6 weeks and you do ultrasonography every 6 weeks, it's not always that you will catch the lymph node in an early stage. You may suddenly find a lymph node low down in the neck at level 4, or you may find a very big lymph node between 2 visits. So that is why if it is a thick lesion, even if it is T1, it is safer to say that you will do a prophylactic neck dissection. Whether you do a prophylactic comprehensive neck dissection or you do a prophylactic selective neck dissection only supramolar, is okay. There's not too much debate about that. But you should, as far as possible, even for early tongue cancers, particularly tongue cancers, it is safer to opt for a prophylactic neck dissection, unless it's a very, very minimal. This last Thursday, Dr. Mohsin and I removed a tumor which was just barely 2 millimeter, not 2 millimeter thick, 2 millimeter in size. There you can just do a wide local excision with clear margins and staple. But on all other cases, it is safer in the exam to go for a selective neck dissection, a prophylactic neck dissection, whether selective or comprehensive. The next, Sandeep, shall we go to the next case?
Okay, sir.
So two things we have talked about in this last case. One is that really MRI is not really indicated for such a small case, but two, that a prophylactic neck dissection is necessary. And the way Sir has pointed out, how the assessment should look at, how you look for whether it is extending towards the floor of the mouth, towards the contralateral side, towards the base of the tongue, those assessments are very essential. And most of those can be done clinically. Okay, next, Sandeep.
Sir, my second case is about 45-year-old gentleman, sir. By name Mr. Suresh Shahu, residing in Andheri, who is a chronic tobacco chewer, smoker with no comorbidities. Came to the OPD with chief complaint of painless ulcer in the right side of the tongue, sir, since 2 months. This is the lesion, sir. The facial asymmetry is maintained, and there is no oral submucosal fibrosis, no trismus, a solitary ulcero-proliferative lesion of size about approximately of size about 2 into 1 centimeter, present in the right lateral border, anterior 2/3 of the right lateral border of the tongue, which is about 2 centimeters, which is about 1.5 to 2 centimeters from the tip of the tongue, not involving the tip of the tongue, and the induration is about extending about 0.5 centimeters all around the lesion, and it is not involving the floor of the mouth, or it's not reaching the base of the tongue. It's not crossing the midline.
Okay, one important aspect you have not described in this lesion, Sandeep. Show the slide again. Not this.
Go back.
Show the clinical picture. One of the things that I think the postgraduates need to see here is the dysplastic mucosa in the vicinity of the lesion. And what we need to remember is that leukoplakias and erythroleukoplakias, particularly on the tongue, are very, very sinister. There are many leukoplakias that we do not tamper with. We just leave it, just do a regular follow-up examination. But leukoplakias on the tongue have to be treated with a lot of respect. And if there's a localized leukoplakia or a leukoerythroplakia on the tongue, it is always safer to excise that and document what it is. Is it only hyperplasia, or is there a lot of atypia and dysplasia, or is there a carcinoma in situ? In this particular case, I think, Sandeep, you can see that there is a lot of dysplastic mucosa behind as well as in front. Behind, posteriorly is all the leukoplakia, anteriorly is an erythroleukoplakia. And it is from one of these areas that this whole lesion has arisen. It shows how these lesions are precancerous and lead to a full-fledged cancer. And I want all the postgraduates to see this slide. You agree with me, Prathamesh?
Very much so. Sandeep, can you go to the next slide where you showed with the anterior? Yeah. So this you can, see what Dr. Pradhan was trying to convey. There is a bald patch surrounding the lesion. So there is that this is not occurred overnight. There's been a long process where there have been pre-malignant changes starting from the leukoplakias going on to dysplasias and then carcinoma. Along the way, the papilla get lost. So you can see how there is a bald patch around the tongue, which might lead you to questioning the margins. So when we are looking at margins, do not just focus on the lesion. Look at the non-homogeneous leukoplakias. Look at the bald patches around the tongue, and you need to focus on these areas. There has been a lot of consideration about the changes in the mucosa, which can be actually looked at by narrowband imaging. So going ahead, there might be some way wherein we can actually decipher what should be the margins, whether it is 5 millimeters, 1 centimeter, or a vascular change beyond which there is a normal mucosa. So look at the lesion carefully, document all the leukoplakias, especially the non-homogeneous leukoplakia and then erythroleukoplakia.
So once again, let's go back to the students on this lesion. That he will, of course, need a wide glossectomy, and Dr. Pai will give us all the different nomenclatures of wide glossectomies and the hemiglossectomy and the neck dissection. And then we should try and discuss what will be your indication to repair the defect and how will you repair the defect. But before we do that, we can ask Dr. Karthik to, in this case, you will do an MRI?
Yes, sir. I will do an MRI, sir.
Yes. Dr. Karthik?
Yeah, it's a no-brainer. Definitely MR is going to have a significant value add. I would also like to add, even in early T1 cases, I don't think, or in T1 cases, it's not what I would say that every patient will not get imaging. There are a subset of patients who will get imaging because if you're palpating the lesion, you're saying that, okay, the thickness, you cannot feel it between your fingers, but there's something palpable in the neck. And you just want to, or you get a kind of an abnormal or an aggressive biology on histology, you would probably want to know the depth of infiltration. And one point I'd like to clarify is that MR done in a very high-end way on a high 3 Tesla with a very unique form of imaging gives you significant amount of value-add information. Yes, for the nodes, MR is slightly ambiguous yet, with about a 2/3, 60%, 70% specificity to a particular diagnosis. But for the primary lesion, MR adds significant value add if done very, very well. So even in about, I would say about 1/3 of my T1 cases, I do an MR, but that's also based because of certain clinical criteria which were there, which were used. And of course, MR does a lot better than just pure clinical examination in those cases when you're looking at the tongue. So yeah, now like in this case is an absolute thing that MR will be the modality of choice to image the tongue. And I do have the imaging. So should I share that, sir, if that's okay?
Yeah, before you do that, I will add one more comment to what you have just said.
Yes, sir.
And I think, Prathamesh, you can respond to this. MR for small tongue lesions is very important if your clinical evaluation is not satisfactory.
Correct.
And very often that is the case when you have very bad submucous fibrosis.
Correct.
Sharp teeth, bad submucous fibrosis, and you are not able to feel. You can see that the lesion is small, and you are going to operate on him.
Yes.
But you just cannot put your finger in and palpate very well. Even under anesthesia, there's a certain limitation. I think those kinds of small lesions, it is always better to have a proper MRI and be aware of what is its depth and what is its extent into the substance of the tongue. So I do agree with you, Karthik, that there is a role for MRI even in T1 lesions,
Yes.
particularly when there is submucous fibrosis and evaluation is difficult.
If I may also add one more point before this, is that even the location of the lesions. So by and large, most of the lateral border lesions are middle third. But when I get lesions going more posterior, sometimes because of third, second, constant irritation, you get posterior lesions and you really can't get back and see really what is the extent, or undersurface lesions when you're looking close to the floor of the mouth. And we have actually seen, so that first case where you mentioned that there was a lesion, I would have loved to review that imaging again, because sometimes aberrant salivary gland tissue can mimic because they're very hyperperfused. But we have seen in a good number of early T1 cases, which are posterior, along the close to the junctional zone, you could say, between the anterior two-third and the posterior third, or towards the undersurface, that they do have skip lesions. And a very important point is, I'll just mention this, is when we do our imaging, we actually use our residents actually photograph every patient of buccal or tongue lesions, and we actually use that in our reporting as well, very clinically, because that really adds value to us. So, for example, like in this case, we actually call something as the umbra and the penumbra. Now, what I mean by that, for the beginners, is umbra includes the area which is probably leukoplakic, which is not classically malignancy, but that border zone which is at that fringe of the malignant tumor, and it kind of forms an interface with the normal parenchyma or the normal tongue substance. And that is a kind of a fuzzy area, because that usually kind of shows certain parameters which are very similar to the primary, but certain parameters don't go bang on as the primary. So I would really say that even in early T1 lesions, it's very important for us to map the entire lesion with a very accurate limit to make sure that we don't miss the penumbra, because tomorrow that's where you cut in a wide local excision where the recurrence is going to happen. So that's what I feel the MR really gets value add on to that.
I think it is very important, what Karthik has brought about. The lesion, as it expands into the tongue substance, increase in depth. The tongue is a muscular organ. So there are various muscles which form the tongue. As you go deeper down, the more and more number of muscles are involved, fibers are involved. It comes in close contact with the nerves, the neurovascular bundle. So as Karthik mentioned, you would have the satellite nodule formation in lesions which are, going from 1 millimeter onwards, more than 5 millimeters, and more than a centimeter. So as it becomes more deeper, the chances of satellite nodule formation increases. So like Sir said, in patients with oral submucous fibrosis, where the mouth opening is poor, where the lesions are more posterior, coming onto the tonsillolingual sulcus, where the lesions are coming onto the floor of the mouth, and when you are palpating something in the neck and you're finding it could be an indeterminate node, these are the indications for doing an MRI. There was a comment on the chat box whether a CT scan will do, and 100% in these cases you should do a MRI and not a CT scan. I think Karthik will focus on that later. In the earlier case, I would definitely want more information about the contralateral genioglossus bundle involved, because that makes a big difference counseling the patient for reconstruction versus not. So these kind of informations are available with an MRI, whether it's involving the ipsilateral genioglossus bundle, is it crossing the midline septum, which is seen beautifully with a fat pad, and whether the contralateral genioglossus bundle is involved. It makes a big difference today whether you're going to leave it raw, whether you're going to reconstruct it, or you're going to close it primarily.
Sandeep, you have a video of this case, or
no, sir. No, sir, video was not there.
Okay, all right. So Karthik, you can just start with the MRI stuff now.
Okay.
Little bit of basics and then the MRI of this case itself.
Okay. Just give me a second. I'll just load it in.
Actually, Dr. Prathamesh, I asked this because many patients do come with CT and many
Yes.
times that does not give much information. That's why I wanted to clarify because many people think that they have got a CT that will tell
Right.
all about the neck nodes and everything. So that's
Right.
the reason I wanted to.
Very important, Dr. Munka, because the first investigation people order is a CT scan,
Yes,
and little realizing that the tongue versus buccal mucosa makes a big difference.
right.
So it is very important that if you see a soft tissue element predominantly in a head and neck cancer, you would be benefiting from an MRI rather than a CT scan.
Sure, sure. That's agreed. Thank you.
I'll just share my screen now and I'll try to show the first case which we just discussed. Okay, so if I'm correct, this is the gentleman, a 61-year-old male. Is that the first patient? Suresh Sahu, right?
Yes, sir.
Yeah. So I would just like to kind of, before we talk about describing the lesion, I would like to say that there are different types of magnets, 1.5, 3 Tesla magnets, and we work only on 3 Tesla magnets for the last 10 to 12 years on head and neck imaging, simply because the amount of information you get is substantially more than on a 1.5 or a low field magnet. Now, for example, now if I were to just tell you or walk you through the anatomy of this entire thing, unfortunately, there are not many images on this case. There are only a few limited images available, but this is what we call the coronal plane. That means you're coming right anteriorly, so that's the premaxillary area as well as the central arch of the mandible. And I'm going backwards, I'm walking all the way back, and I'm seeing the tongue which is coming up in this section. Now, just to basically show you a few anatomical structures before we kind of go into the pathology, is this bright structure which you see in the midline is what we call as the median raphe or the lingual septum. Now, this divides, now I don't want to get into the embryology of the tongue, but by and large, this is the median shelf of the tongue which kind of divides it into two equal halves, the right and the left half. Now, this is of strategic importance in tongue cancer because it impacts the way the surgeon kind of resects the tongue and also impacts the resection and the reconstruction of the tongue. So it's very, very pertinent that we are always able to assess the lingual septum and the raphe. Now, ideally, you want to assess any structure in the tongue in two planes because we work on three-dimensional anatomy, not two-dimensional. So this is the first structure which you should remember, this midline structure, which kind of acts like a strut. When I come slightly, I'll drag this all the way down, which is the median raphe lingual septum. You would see two, actually it's not showing very well, it's a very low field scan, but there are two blobs, one below each other sitting up out here. Now, this is a very important structure because this is the root of the tongue, and the root of the tongue basically consists of two pairs of muscles or what I would say tendons, which then fan out as muscular fibers. The one on top is the basic strut of the tongue, the major dominant extrinsic muscle, and we call that the genioglossus, which starts up here. So if you look carefully, genioglossus would kind of fan upwards into and form the basic strut or the framework of the muscle. So you can see both the genioglossus sitting here. These are absolutely critical structures to report on your MR, whether the extrinsic fibers are on. Of course, the staging has changed. Before, we'd have a lot of weightage on which muscle is involved. Now we don't have that much of weightage. We don't describe each muscle, but these are very key points to remember. The genioglossus itself. The one below is the geniohyoid, and it's very easy to actually trace that muscle. You can see that muscle going downwards, and it'll go and merge with the hyoid bone, which is actually the central strut of the neck, which is very important. That's the hyoid bone, and you can see the geniohyoid muscle coming in, attaching up over there. So you have the lingual septum, or the median raphe, and then you have the paired genioglossus and the geniohyoid muscles. Important structures to remember as part of the floor of the mouth, which I would say segregates the sublingual space or the floor of the mouth from the submental and the submandibular space, is by a sling-like structure. This sling-like structure is called the mylohyoid muscle. Now, if you look carefully, the mylohyoid attaches laterally onto the mylohyoid line, which runs basically along the inner margin or the lingual cortex of the mandible. Now, this structure is also very important when the mylohyoid line runs, is because the posterior edge of the mylohyoid line gives attachment to the pterygomandibular raphe. Now, that's a very, very important structure because that typically gets affected in patients with submucosal fibrosis, or when you get RMT involvement, you get trismus, and that prevents mouth opening. So please remember, lingual septum median raphe, genioglossus, geniohyoid, the sling-like structure, which is basically the mylohyoid muscle. Now, this mylohyoid kind of compartmentalizes you would say the structures in the oral cavity into a sublingual or a supramylohyoid and a submylohyoid component. The submylohyoid structures, which you've got to be remembering very carefully, of course, is the anterior belly of the digastric, and the anterior belly of the digastric divides the submental space from the submandibular space by and large. So you would typically, when you get tip lesions, like lesions along the tip of the tongue, you would have to look for submental nodes. And as you start moving towards the lateral borders, the mid and the posterior third, you would start looking for structures in and around the submandibular gland itself. So this is a submandibular space. Please remember one thing, that the mylohyoid sling is not a continuous muscle in a good number of patients. There are developmental defects in this muscle, and many a time sublingual glands can actually protrude below the mylohyoid shelf and actually go into the submental space or the submandibular space, and these can mimic tumors which are actually reaching the floor of the mouth. You've got to be very careful because on MR, they have a very similar so whenever it's a skin lesion, I'm very careful to make sure this is not hypertrophied salivary glands, because many of the patients with oral cavity cancer have a lot of inflammation going. No tumor comes without inflammation. And most of these patients have got hypertrophied minor salivary glands and occasionally larger sublingual glands itself. So it's very important to identify this. So once you get to the lingual septum, the structures along, which are basically the two major extrinsic, the genioglossus, which is one of the major extrinsic, I start looking what is the intrinsic muscles of the tongue. I'll come to the remaining extrinsic muscles in a few minutes. This is the dorsum. You can see the palate on top. You can see the dorsum of the tongue. Just beneath the dorsum, beneath the mucosal surface, this band-like structure is the first intrinsic muscle of the oral tongue, which we call the superior longitudinal muscle. Now, this muscle, of course, we don't have value add when you're writing which muscle is called, but this is an important fiber which basically constitutes the curvature of the dorsum of the tongue. Immediately below that, you get a decussation of fibers which run at orthogonal planes to themselves. So they run at 90 degrees to each other. And this decussation, which you see here, is a combination of the longitudinal or the vertical fibers and the transverse fibers. So by and large, if you really look at it carefully, the arc above is the SLF, and this is basically a combination of the vertical and the horizontal fibers. The inferior longitudinal muscle is located more caudally, and it basically forms along the undersurface of the tongue, and it is in very close contact with a very important muscle, which we call the hyoglossus. Now, where is the hyoglossus? The hyoglossus is seen here. This is the hyoglossus muscle, and why is it so important? The hyoglossus muscle is the second most important extrinsic muscle when it comes to the anatomy of the oral tongue. And why so? The hyoglossus muscle basically divides the sublingual space into two components on imaging. The one which is medial to it and one which is lateral to it. Now, why is it so important? The lingual artery typically runs medial to the hyoglossus after it comes within the potential submucosal space, whereas the vena comitans, along as well as the lingual nerve basically, which is again a continuation of the B3 division, and of course it takes some sensory fibers along with it, runs lateral to the hyoglossus. So ideally what happens is you can identify the hyoglossus, you can identify the mylohyoid shelf running up here, and the gap between the two You see this dot sitting up here, that is the lingual nerve itself. So in every MR, I need to identify the lingual nerve very carefully. Now, when I run posteriorly and I reach the edge of the mylohyoid, so what I call the edge of the mylohyoid shelf, I basically have the superficial and the deep lobes of the submandibular gland, which are straddling the edge of the mylohyoid shelf. Now, why is it so important to identify the structure? It's important to identify the structure is because the hypoglossal runs about 5 to 10 millimeters caudate to the lingual nerve. So whenever you have posterior third lesions, you've got to identify the relationship of that tumor sitting up here to the mylohyoid shelf, the higher glossus, the fat pad between the two, and of course, when you run posteriorly, you identify the submandibular gland, you've got to identify the relationship of that tumor to the hypoglossal nerve. So whenever you have T2 tumors or T3 tumors which are far posteriorly placed, it's very, very pertinent that we identify these structures very, very importantly. So this basically runs what I would say a standard anatomy. They don't have, unfortunately, actual images which are pre-contrast, but they have got a post-contrast image. And just to kind of reiterate this, I'm going to show this to you on actual images. What you see which is enhancing out here is not tumor. This is normal sublingual gland. This is normal sublingual gland. So there is often a misnomer that even when you do post-contrast CT and you start seeing early T1 lesions with hypertrophied sublingual glands, people end up calling that also as a tumor sitting up in the sublingual space or skip lesions. These are not, these are just normal structures which are seen out here. Plus remember, the sublingual gland is never one gland itself. It can be a consortium of smaller glands which are randomly scattered along the length of the sublingual space. And how I look at it is, the oral tongue has got a potential submucosal space, and there is a true submucosal or a sublingual space, which is the floor of the mouth itself. So when tumors actually come into that area, they incite a lot of reaction in the surrounding glands, and they cause a lot of hypertrophy of those glands very, very clearly, and it's usually asymmetric. Now, when it's asymmetric, you can see the right sublingual gland is far more hypertrophied on the side of the tumor sitting up here, whereas the left gland is far more smaller because the amount of inflammation which generally goes along with the tumor is far, far less. So we see this very often and we are very careful about it. The second thing which you should always remember, in this case, it seems that the right submandibular gland is atrophic or is not seen, but the left SMG is right up here, and you've got to identify the structure running up here. That is the Wharton's duct and the lymphatics running along the Wharton's duct, which actually is located in the sublingual space. Now, why is it important? Whenever you have sublingual infiltration or floor of mouth infiltration, there are three structures which typically get affected. From anterior or from medial lateral, you'll be the lingual artery. You'll have the lingual nerve along with its vena comitans, and third would be the Wharton's duct. So an indirect evidence when a tumor reaches the sublingual space, it doesn't have to be infiltrated. If it's a very large endophytic growth, where a lot of the tongue cancers can be endophytic, not proliferative, they can have a mass-like effect on the sublingual space itself. And they can actually compress the duct in its terminal third before it enters the frenulum. And you can get ductomegaly. And when you get ductomegaly, you get post-obstructive sequelae in the gland itself. So you've got to remember this, that of course, there is always direct infiltration, but large volume tumors can also have a mass effect and a compressive effect going on out here. Also, you got to remember very clearly that you have to identify the junctional zone. Now, this is the tip. You would look at I would divide the oral two-thirds or the anterior third of the two-thirds of the tongue into three parts, an anterior, a middle, and a posterior. Based on the location, I keep my eyes very open on certain things. So when you have lesions which are closer to the tip, I'm worried whether the disease is going to have bilateral nodes in the submental area, may cross over very early. The classic case scenario is a middle third, which is seen up here, typically between the premolars. So when you have disease between the premolars, it's a classic middle third disease, and you would expect that usually it's unilateral distribution of nodal involvement. When you have posterior lesions, now this is where the challenge happens and where MR is really useful, is that MR can predict the posterior most extent of the disease. So which may be restricted if the patient has got SMF, limited mouth opening, very sharp teeth, bad dentures, so on and so forth. And this allows us to identify a very critical structure, what is called as the glossotonsillar sulcus or the tonsillolingual sulcus. Now, this is a very important structure because this allows disease which is primarily located in the anterior two-third to have either a mucosal or a submucosal spread into the posterior third, or alternatively, it can get into what I call very critical structures. One is the anterior tonsillar pillar or the palatoglossal arch, run up to the soft palate, or laterally, even tumors sitting up here can end up going into the retrotrigone. Very, very critical structures. This is the RMT. And posteriorly, you have a very important space, which is the parapharyngeal space. So when you have tumors which are seen very well anteriorly, the posterior extent is limited. You need to map out the posterior most edge of the tumor, which is going to allow the surgeon to ideally plan the surgery and reconstruction in these cases. So that is what I would say on basic anatomy of the tongue and the key structures. Now, sir, if you want, I can finish this case and I'll leave it here. I'll show this case.
Yes, please.
Yeah, so in this case, you can see the classic presentation where you have a I would say a kind of a challenging disease in terms that there is a proliferative component on the surface. And of course, you have an endophytic component getting in as well. Now, what is very important to remember, I'll kind of show it to you on the pre-contrast T1 out here. And if you all can see this, 1 second, I'll just move it off here. I prefer this sequence more than anything else. Now, very important for us to remember is what I call the depth of infiltration. Now, that is a single most important parameter why MR has come into vogue, because you can, if you feel a tumor between your two fingers, it's usually a centimeter in thickness. Anything beyond that, you know that your DOI is definitely in the range of 10 millimeters. Now, how do you actually calculate the DOI is a challenge, but I'll probably take it at another time. But by and large, we are measuring thickness of the lesion. Now, and thickness, because thickness would be including the proliferative component of the tumor. Here, I would be just purely looking at it from the surface of the lesion or the tongue itself. So by and large, if you take this as the contour of the tongue, you would be measuring your DOI in some form like this. So it's about a 6 to 7 millimeter depth of invasion. Now, beyond that, what we actually do, so we don't measure. So this would be the thickness. The thickness, because it's coming above the surface, you would say the thickness is about a centimeter plus, or 1.1 to 1.2 centimeters by and large. Of course, I would prefer to do this on my console, whereas the depth from the surface is about 6 to 7 millimeters. More importantly, what information we always give is what is the leading edge of the tumor in two planes. A, in the coronal plane, because you want to know what is the distance of the tumor to the median raphe. Now, that's an absolutely critical point because that affects the extent of the surgical resection and how much of residual tongue is going to be there. And then, of course, whether reconstruction is required or not. So here, I would make a note that, of course, the depth of invasion is so-and-so, and the leading edge of the tumor is located so many millimeters from the median raphe. Now, that's absolutely critical. And, of course, we use our functional sequences to make sure there is no skip lesion sitting here. Because many of the time, if I were to put the contrast image, I'll just move this to one side. If you would put the contrast image, and this is where the fallacy lies, if you look at the same level, and if I were to take the amount of tumor depth on the contrast image, it will always be far more than what you see on the pre-contrast image. Because there is always a flare, and the flare is because of the surrounding inflammation and the surrounding leukoplakia and everything which is going there, which is yet pre-malignant. It's not cancer yet. So we don't advise a standard post-contrast MR in these patients. We actually ask for functional imaging of the tongue, and we have been doing that for a long time. We actually look for mismatch in tissue cellularity, and we actually then predict what exactly is going to be the depth as well as the extent of the disease from the median raphe. So that's very important. The second thing to remember on the coronal plane is, though tumors have a proliferative component, they use the scaffolding of the tongue musculature to spread in a mediolateral and a craniocaudal extent. So here in this case, what happens is, these are the lateral fanning fibers of the genioglossus. Now, there is going to be some involvement of genioglossus, but it's the peripheral fibers of the genioglossus which are affected on this imaging. But more importantly, what it does is the tumor uses the intrinsic muscles, that is the vertical as well as the longitudinal muscles, and uses that as a scaffolding to get into the undersurface of the tongue. So if you lift the tongue, you will find that the tumor is not only on the lateral border and the dorsum, but the tumor has gone on the undersurface of the tongue and is now in very close proximity to the superior most edge of the floor of the mouth. So by and large, the patient has got no fixation, no ankyloglossia, nothing happening over there. The tongue movement is intact. You know that the tumor has not yet infiltrated and got fixated onto the floor of the mouth. But if you look very carefully out here, I'm going to magnify the image, and I'll just put some arrows for you guys. That's the inferior edge of the lesion out here. And this is the hypertrophied sublingual gland, which is sitting up here. So you can appreciate that the tumor is within a couple of millimeters, or actually is really in touching distance of the floor of the mouth. So you've got to be very careful when you're looking at this. Now, what happens is we also give this distance. So once we have given this distance, we have to be carefully seeing whether the lingual nerve is affected. So I'll show you where the lingual nerve is, and you can actually identify that very beautifully on this imaging. This is the lingual nerve. Now, we know that the lingual nerve typically arises from the sensory division of the V3 of trigeminal, typically between the ramus of the mandible and the medial pterygoid. And that basically is a confluence of three nerves: the lingual, the auriculotemporal, and the inferior alveolar. The lingual nerve kind of swerves over the pterygoid complex, then moves into the area of the along the pterygomandibular raphe and the posterior edge of the mylohyoid shelf. And you can actually see the nerve here beautifully. That's the medial cortex of the mandible. So whenever I have disease reaching up to this location, I now not only have to look for the hyoglossus going, but I look for the lingual nerve in the sublingual space. I have a potential chance that if the tumor has gone down and it's abutting the medial cortex, I can have marrow infiltration and mandibular involvement along the medial cortex. So typically you would not get that, but in aggressive T4 disease, you can get bone involvement simply because of the location of the disease sitting up here. So here you have what I would say a lesion which is kind of proliferative with an endophytic growth, with a depth of invasion which is probably just short of 10 millimeters, with a good distance with the median raphe, in close proximity to the FOM, but not infiltrating the FOM, with sparing of the lingual as well as the hypoglossal nerve complex. And that's where I would leave it from the structural point of view of the tongue itself. Yes, sir. I'll just stop sharing. Yeah.
Any questions for Dr. Karthik? We will have more cases where he will show further MRI lesions. Prathamesh, you want to ask them something on this case, or should we go on to some more advanced lesions?
So I think we had discussed about the clinical features, and now we have seen the radiological features. So Sandeep, any change in your plan for surgery? So what I'm trying to get at is you had a clinical evaluation of where the lesion was. Now it's supplemented with the radiological imaging. So you know now.
We'll plan.
Little louder.
Sir, I will plan according to the distance. The lesion is about as in the MRI it's told about 1 centimeter from the median raphe. So I will plan for the wide excision, sir, wide local excision of that lesion, which is about, I will plan about 1 centimeter, so that I will get about 0.5 millimeters after in the pathological specimen. At least I will plan about 1 centimeter, so that in pathological specimen after contraction I will get about 0.5 centimeter margin.
So what you are telling us is the margins. So you're going to plan for a centimeter margin all around.
Yes, sir.
Now you get some additional information from imaging. You know that it is close to the sublingual gland. It is close to the lingual nerve. Would that change your plan? Would you then factor in the resection of the sublingual gland and the lingual nerve?
Yes, sir. Clearly.
So what we need to understand is clinically, you at the time of surgery, you will resect what is required. Many times imaging will give you overestimation of the extent of lesion because primarily it is taken in when the tongue is not moving. You're seeing the clinical features, you're seeing that the tongue is completely free of the floor of the mouth.
Yes,
So, of course, you will be guided by the imaging, but when you are operating, you will pay more attention to where is the infiltration, where is the induration, and plan your margins accordingly. So, do we go to the next case?
Yes, sir.
Take this third case, Sandeep.
Amanat Khan residing in Gorakhpur, sir, who is a tobacco chewer and
We cannot hear you clearly. Can you speak a little more?
yes, sir.
Closer to the mic.
Yes, sir. Residing in Gorakhpur, who is a tobacco chewer and a smoker and an alcoholic with no comorbidities, came to the OPD with chief complaint of ulcer in the left side of the tongue since 5 months, which is started approximately of size 1 into 1 centimeter, gradually added to the and it's associated with pains. There is no
आवाज नहीं आ रही है. Can't hear it.
on local examination, facial symmetry is maintained and the submucosal fibrosis is present and trismus is present, sir, grade 1, and tobacco staining all over the oral cavity, all over the dentin, and the ulceroproliferative lesion of approximately of size 4 into 3 centimeters present in the left lateral border of the tongue, in the middle third of the anterior two-third of the tongue, which is reaching up to the tip of the tongue and not involving it, with irregular margins, and the ulcer is which is with averted edges, and the base is on the swelling, and it bleeds on touch, and it's not crossing midline, and it is involving the floor of the mouth and is reaching up to the base of the tongue, which is not involving it, and the tongue movements are restricted. On protrusion, there is a deviation of the tongue to the left side, and there is no ankylosglossia, and there is no cervical lymphadenopathy, sir. These are the images, sir. This is the deviation of the tongue towards the side of the lesion. Video, how to play the video.
मुंह खोलिए. The patient has mild OSMF.
And the lesion is right lateral border of the tongue, and tongue movements are restricted with deviation of tongue towards the side of the lesion, and the supraomoid tissues are supple. Yes, sir.
Okay. So, do we have the imaging for this patient?
Yes, sir.
So, Karthik, would you be discussing the imaging?
Can you all see the screen?
Yeah, we can.
Okay. So I'll kind of show you all a different plane because I think the patient is not cooperated very well. But let me just see if I can get some good images. Yeah. Okay. So as seen clinically, you have a very large volume lesion, which is seen in the left half of the oral tongue. And kind of by the way it looks, the lesion is causing a lot of architectural distortion. So it's ulceroproliferative, you have the overhanging edges, and you see a larger or a deeper endophytic component of the lesion, which is sitting up here. Now, the action images actually are better in this patient, but I'm kind of to show you all where the lesion is. So to get you all a sense of normal anatomy on this, so that's a normal right side surface. You can see the black line, which is kind of maintained. But here you have a very large ulceroproliferative growth, which is kind of distorting the architecture of the tongue itself. Now, just to come to the most important points, I'll just kind of show you all the hyoglossus muscle on the imaging, just to kind of reiterate the fact. So I showed you all the coronal plane. So this is the genioglossus tendon, and these are the fibers of the genioglossus fanning upwards. You see this black structure down below here? Now this is the hyoglossus. I can go all the way down and I can trace that to the body of the hyoid bone, and this represents the hyoglossus. Now this basically forms the lateral or the inferolateral edge of the tongue, and it's a very important structure because you can see that it's close proximity to the mylohyoid, which is sitting up here. That's the paired mylohyoid. You can see the one here on the right is the one on the left. That's a hyoglossus, and you can see that at the free edge of the mylohyoid of the shelf, you can see the submandibular gland kind of clenching onto the mylohyoid itself. Now, why this is important is, now if you take the location of the hyoglossus, you can see that the lingual artery is typically on a plane which is slightly more medial to the muscle, and you have the nerve and the fat which is there in the pure sublingual space located just lateral to the muscle itself. So that's very important to remember. Now, let's look at this case for a second. You can see this growth, or what I would say a darkish lesion sitting up here. You can see the architectural distortion. It's a pretty large, deep endophytic lesion. You can see if you take this as a surface, ideally that's the ulcer head. So the depth of infiltration would actually be significant. It's about 1.4, 1.5, so it's greater than 10 millimeters. And you can make out that the lesion, if you see the leading edge, is within a few millimeters of the raphe, 4 millimeters of the raphe itself. Probably at lower sections, even more closer. Now let's go down, and you would see that where we're coming to the floor of the mouth, and you can see the hyoglossus here. That's the mylohyoid. Now concentrate onto the left muscle. I'll show you all the left first, which is normal. Sorry, the right, which is normal. You can see the mylohyoid you can see the sublingual gland, and typically you can see the fat surrounding. The bright areas are the fat. So normally the presence of fat suggests that the plane is pretty much intact. Now let's look at it on the contralateral side. On the contralateral side, you can see that this large volume lesion has kind of insinuated between, has taken out the hyoglossus itself and is insinuated between the mylohyoid shelf and gone lateral to the hyoglossus muscle itself. So this, you have clinically frank floor of mouth invasion, and imaging also corroborates with that there's substantial amount of floor of mouth involvement, and you can see that the lesion has actually gone very close indeed. So if you see that this is all tumor, normally this is the bright spot. You can see the bright spot here. The bright spot is fat. The absence of fat on the opposite side clearly tells you how the tumor has not only infiltrated, but now it's insinuating between the hyoglossus and the mylohyoid out here. And this has basically reached literally up to the free margin or the free edge of the mylohyoid itself. That's a submandibular gland. The tumor is now in very close proximity to the deep lobe of the gland itself out here. So you know the lingual nerve is probably gone, and you have to be very careful, and you got to see whether the how close is this tumor to the hypoglossal nerve. Ideally, the hypoglossal is located here. In this case, I don't think the hypoglossal would have been involved. More importantly, you're seeing enlarged nodes at level 1B, which can usually be seen when you have tumors of this size. So when I'm just magnifying that image, you can again appreciate it. You got level 1B nodes sitting up here. I don't know whether the level 2s are there. There are probably small level 2s out here, but that is pretty much a large volume lesion sitting up here. Important to remember that we always go all the way beyond the junctional zone and the tonsillolingual sulcus. This is pretty much free, and there is no extension of the disease into the base of the tongue. I'll stop sharing now. Yeah. Yes, sir.
Karthik, that was very nicely shown. Could you just to put the images back up? We need to just discuss that, reiterate the point which you have shown so well.
On which point you want me to reiterate?
The one you're just showing the actual view, showing the tonsillolingual sulcus.
Okay, I'll just get back to that. So I think, yeah, I'll kind of show it out here, and then I'll run it down slowly. Okay.
Yeah.
So 1 second. Okay. So this is basically what ideally you would have, if I just put the sagittal image and kind of show you all how it's done. So if you look at the section, it's basically, this section is taken probably through the midsection of the oral tongue. And this is the palate which is coming out. You can see the uvula sitting up here. Now, this is the actual representation of this cut which is seen on the sagittal. I'll take out the sagittal, and just to make you understand, this is the tongue which is seen. This uvula is a part of the oropharynx. Now you're coming in oropharynx itself. So as you go below the tip of the uvula, you start getting into the oropharynx. That's the lateral oropharyngeal wall. And you have now started to see the anterior tonsillar pillar, the faucial tonsil, and the posterior tonsillar pillar. So you've got the palatoglossal arch and the palatopharyngeal arch, which basically arches into the posterior pharyngeal wall. The important thing to remember is this anterior tonsillar pillar is kind of where you have a junctional zone between the tongue. You can see this black line curving up here. I'll just magnify this. I'm kind of making it bright purposefully, and I'll kind of reiterate this point. So you have the tongue coming up all the way here, and it kind of dips into a sulcus or a crevice, and then continues into, this is all part of one continuous mucosal lining itself. So this is very critical to be analyzed in every case. This is where you will look at the tonsillolingual, because now disease getting into the tonsillolingual sulcus has got extension into the anterior tonsillar pillar or the palatoglossal arch, therefore the lateral oropharyngeal wall, which is immediately posterior, or it can climb along the palatoglossal arch into the soft palate, or it can go laterally into the RMT, and therefore the RMT can go into the buccal, or go even higher up into the retroantral fat pad. More often when you have GTS involvement, you've got to be very careful to carefully analyze the pre-styloid parapharyngeal space, which is located right behind the structure. You can see this fat pad here. this is a very critical structure, because now this, if a tumor gets access to this plane, it kind of got a free way. It can go to any planes, whether it's superficial or the deep cervical spaces. It's got access to the alar fascia and to the prevertebral. And out here, it's got straight access into the masticator space, which kind of makes it a complete no-no. And therefore, skull base involvement, V3 involvement very commonly at this location, the main trunk, can also get affected. I hope that
kind of put downwards now, showing us the submandibular gland.
Yeah, I'll show that to you. So I'm coming down, and you can see the SMG here. That's the SMG.
So, so the residents should know this, because you're getting a multiplanar imaging on MRI, and this is very critical for you to see in all the three planes, the axial, coronal, and the sagittal. What is critical to understand is, as the lesion goes posterior and it comes onto the mylohyoid, you know that when you resect the submandibular gland, the mylohyoid muscle, and the hyoglossus, you will be opening up the neck at the level of the vallecula inferiorly. So you would have a communication between the oral cavity and the neck, and you will have to reconstruct the floor of the mouth. So the importance of the imaging is to understand what you'll end up resecting and how you're going to reconstruct. So very beautifully, Karthik has shown how the lesion is coming on to the mylohyoid muscle as well as the hyoglossus, as well as posteriorly coming onto the submandibular gland. So this would entail resection of almost the 2/3 anteriorly of the tongue and coming onto the base tongue posteriorly.
How will you resect it is the question that we need to ask the students. What would be the approach? You saw that in the first 2 or 3 cases that we saw, we can do an intraoral wide glossectomy, hemiglossectomy. Is this a case that you can approach intraorally? No. Isn't it? How would you approach this case for resection? In the video clipping that Sandeep showed you, you saw that Dr. Mohsin was palpating the suprahyoid tissues, and that was mainly to see that the tumor is not coming through into the suprahyoid neck tissue. When the tumor is coming through and through into the suprahyoid neck tissues, most of the times this is unresectable disease. So he saw that that area was supple. So this is an advanced but operable tongue cancer. How do you approach surgery or resection of this cancer? What approach will you take? Anybody?
Saujanya can unmute and speak, please.
Good evening, sir.
Yeah.
Good evening, sir.
Good evening.
So we can approach this tumor through a pull-through technique. We can give a wide horizontal incision in the neck. Along with that, we can excise the mylohyoid muscle, hyoglossus, and all the anterior attachments of the tongue, and we can get the tongue into the neck through a pull-through. And the advantage of this technique is we can get a posterior margin, because in peroral or intra approach, it is difficult to access, sir.
So peroral is out. This kind of a lesion which is lateralized, which is causing partial ankyloglossia, considerable ankyloglossia, but does not have any gross suprahyoid infiltration, is an operable cancer, but to operate it intraorally is absolutely harakiri. So one suggestion that you are giving is that it can be done through the pull-through. Is there any other suggestion of how you can approach this? So in a pull-through, what do you do? Can you just describe in a pull-through what do you do? You first do your neck dissection, then you do intra. Would you like to describe how would you do a pull-through procedure?
Sojanya?
Yes, sir. So we give a wiser approach, sir. Horizontal thin neck ridge incision. We excise the submandibular gland, sir. Clear the 1A level. Along with that, we excise the left submandibular gland, 1B region, and then excise the myloid muscle, sir, the floor of the mouth, so that we can reach there, sir. And with an adequate margin, also, sir, we can go posteriorly and excise the myloid attachment, so that the is pulled through the neck, sir, in the submandibular region, and
Yes,
then we
but-
can get the access, sir.
Yes, okay, but when you do that, you'll have to do a considerable amount of the opposite side dissection, the right border resection intraorally. Without that, the tongue cannot be pulled out into the neck.
Yes, sir.
You pull through is one approach,
Yes, sir. Yes, sir.
but please remember that a considerable amount of dissection will have to be done intraorally, whatever area you are comfortable with, on the right border, as far posteriorly as possible, and then along the floor of the mouth, close to the lower gingiva, you will incise the mucosa there, and then you will divide the mylohyoid, and then you will try and pull through. Let me tell you, it is quite a struggle. I want to know what is the other approach. Somebody wrote that the other approach is a wiser approach. What is a wiser approach? I don't know what a wiser approach is for a major glossectomy. But somebody wrote about a lateral mandibulotomy. Is that what you wrote? Lateral mandibulotomy?
Rajesh, you can unmute yourself.
Yes, sir. Yes, sir. I've wrote about lateral mandibulotomy.
Okay. Is there any other mandibulotomy that you can talk about?
We can go by a midline mandibulotomy also, but the lateral is much better. So we
Why
can
is
go
lateral better than, why is lateral midline is not a good approach. A paramedian is a
paramedian. Yeah.
So which of
So
the
I
two
think
is better? Which of the two is better? Paramedian?
Paramedian.
So not lateral.
No, sir. So actually I meant paramedian, but I wrote lateral.
Okay. Alright. So paramedian mandibulotomy and swinging the mandible to one side after you've done the neck dissection. It's called a mandibular swing. That is the best approach that you can have for this lesion. It is the best approach that you can have. Pull through is quite a struggle, let me tell you. Pull through is a good approach for a near total or a total glossectomy, where you can directly detach the tissues from the muscles from the hyoid. Then it becomes very easy for you to pull the tongue out. But where you are not doing a total glossectomy, you are doing a very wide hemiglossectomy or an extended hemiglossectomy, pull through is quite a struggle. It can be done, but it is quite a struggle. And then very often what you find is that I have taken out too much on the side where I did not need to, and too little on the side where I needed to. Whereas if you do a paramedian mandibulotomy and swing the mandible apart, you will resect appropriately on all sides. So paramedian mandibulotomy and mandibular swing is a good approach for this kind of a lesion. You do not need to sacrifice the mandible in this kind of a lesion.
So I think the imaging really helps us in this planning, because you'll know about all the structures that are involved laterally, and you would not head the path of doing a peroral resection or a pull through when you are concerned about lesions coming onto the medial pterygoid, coming onto the anterior tonsillar pillar. Those are the indications wherein you would want to consider paramedian mandibulotomy, because you would get a better control on the lesion, on the muscles such as the mylohyoid and the anterior tonsillar pillar, in order to excise it posteriorly. So as we had seen the lesion coming very close to the tonsillolingual sulcus, it would be ideal for doing a paramedian mandibulotomy.
But even if you did not have access to getting an MRI done, and so often you don't have, I think that a clinical examination and a clinical examination under general anesthesia will give you a very good indication of how severe the disease is and what would be the best approach that you will take. So often we don't have an MRI, even for these kinds of cases. I'm not saying don't do it. I'm saying please do it. But very often you may not have access to doing an MRI. You can still manage this case if you've done a good examination under general anesthesia. You will know what approach to take. We have one more case, and I think we can just take that and discuss it very briefly, because we will not get Karthik once again so frequently. So, Sandeep, you want to show that case? Should we continue, Prathamesh, or should we stop?
Yes, sir. I think we should. It'll give a complete picture to the rest.
Sandeep?
Next. This is a gentleman sort of named Dilip Thakur, who is a chronic tobacco chewer and smoker and alcoholic. The chief complaint of ulcer in the tongue since 8 months, sir. Assured with pain, excessive salivation, and is unable to protrude the tongue out. And there is a difficulty in speech, and there is no dysphagia or voice change, sir. This is severe oral submucous fibrosis, sir, and trismus is grade 2. Ulceroproliferative lesion, which is of size 5 into 4 centimeter, involving the left anterior two-thirds of the tongue with irregular margins and floor formed by the necrotic tissue, and ulcer is based on the swelling, and it is crossing the midline and the bleeding on touch and reaching up to the base of tongue, and the floor of mouth could not be evaluated, sir. And there is a complete ankylosing, sir, and there is no loosening of tooth is seen, and there is no cervical lymphadenopathy, sir. This is the picture, sir.
What is the status of the suprahyoid tissues clinically?
Suprahyoid tissues are not supple, sir.
You don't have a video?
We have the video.
You didn't take a video recording of this?
We taken.
Okay, this is good. So this is the kind of case where I think even a pull through is very good, because he requires a total glossectomy, and you can pull through it much easier than in the lesion that we saw earlier. But Karthik can show us the MRI of this lesion.
Yeah, 1 second. You can see this? All of you can see this, hopefully? Yeah. Yeah. So,
yeah, we can.
So again, this is pretty much a kind of a completely different story as compared to the initial cases, where you have kind of completely replacing the substance. So not only is it's asymmetric, of course, but you can see that both halves of the tongue, the lesion is kind of straddling the lingual septum or the median raphe, and you have bilateral involvement. Of course, it's asymmetric, it's dominant on the left half of the oral tongue. And you can appreciate not only the mediolateral extent of the disease, that is from lateral border to lateral border, but on the coronal plane, you can see that the lesion is from the dorsum, and on the right, it's kind of reached up to just very close to the sublingual. On the left, there's frank infiltration of the sublingual space. You can even see compression of the sublingual gland. And you can see how the tumor, by just its mass effect and its volume, is kind of splaying the mylohyoid muscle, and it's pushing it down. And it's in very close contact with the inner cortex or the lingual cortex of the mandible. I'll kind of go to another imaging, and you can appreciate all the dark stuff is actually the tumor. And wherever you see fat or the bright signal, that's normal tissue which is remaining. And there's not much of it which is there in terms of the volume of the tongue which is preserved. The only good thing is on these images, you can appreciate that is the base of the tongue, the valleculae are kind of spared completely. You can appreciate the hyoglossus muscle here beautifully. It's kind of a lovely C or a crescent, which you can see here. That's the mylohyoid. And on the opposite side, you can see that that fat pad between the mylohyoid and the hyoglossus is gone. And the tumor, you can see how the tumor, I'll just run it up all the way back. That's tumor. And it's coming down. And it's gone right between the potential space. So tumors always look for planes of easy passage. Or it uses normal muscle as scaffolding. May not actually have to go in through the muscle. It can just slide on top of the muscle, and that's what you typically see in the floor of the mouth. It kind of insinuates, normally we call it as infiltrative, but the tumor actually insinuates in the gap or the potential space between the mylohyoid and with the submandibular gland out here. Now this is a pretty large volume growth. But like I mentioned, it's very close to the GTS. It's very, very close to the lateral end of the GTS. Now, why this is very important, the lateral end of the GTS, is for two structures. Anatomically, I can see the lingual nerve there. You can appreciate the lingual nerve. That's beautifully seen before it arcs over and then gets into the sublingual space. You can trace it beautifully. And if I trace the nerve, it typically arcs over the medial pterygoid and gets into this potential space out here. Now, that's the V3 division, the sensory nerve. These three other was the lingual sitting down here. So you can see all the three of them coming together. Of course, the auricular also gets the chorda tympani, which is a branch of the facial, which comes along with it as it gets into its special sensory component out here. So by and large, if you look at this disease, you have a very large volume disease, near completely replacing the tongue substance, but reaching up to the posterior most or the glossotonsillar, lingual tonsillar sulcus, not infiltrating the anterior tonsillar pillar or the tonsil, sparing the lateral oropharyngeal wall, no extension into the prestyloid parapharyngeal space, and of course the RMT is pretty much clean out here. And also probably the pterygomandibular raphe is clean because it kind of inserts right here. That's the imaging, sir.
Karthik, can you show us a sagittal plane as well?
Yeah, I can do that. That kind of shows it pretty much here. So you want me to describe this kind of?
No. Just I just wanted you to focus on the lesion, which appears to be more anterior.
Yes. It is completely anterior. Actually, it's slightly ahead of the junctional zone, and only laterally or posterolaterally it comes very close to the lateral edge of the tonsillar linguosulcus, because the sulcus kind of curves more anteriorly on the lateral aspect. So it is kind of reaching up to there on the left side.
And also, sir mentioned, he wanted to know, he asked Sandeep to show the video because particularly he wanted to know how is the submental and submandibular space. Okay, so when it breaks through inferiorly,
I'll show you.
It's not broken through it.
So because of the location of the lesion, I don't expect this tumor to actually get into the submental space. Now, there are reasons for that, simply because the tumor is pretty much on the upper portion of the tongue. It's not kind of going down below where you would take it along the genioglossus or the geniohyoid. So the root of the tongue is pretty much spared at this location where the tendons are located along the mental or the genial tubercles. And you can actually see very clearly that the anterior belly of digastrix, so that's the central arch of the mandible.
Right.
You can see, I'm going backwards, that's the anterior belly of the digastrix, that's the root of the oral tongue. And when I go backwards, you can see that the submental space is completely spared. Though the lesion on the left is in very close proximity, you can see that's the mylohyoid. And you can see the tumor bulging into it, kind of pushing into it. You can still see it's not breached the mylohyoid at all. It's not gone below the mylohyoid. And posteriorly, it... So if I'm coming... Sorry, 1 second. That's going posteriorly. If I come anteriorly, you can see that it's not gone into that. It's just reached up to that space here compared to the opposite side between the hyoglossus and the mylohyoid. It's reached up to this location. So it's not gone beyond that. Because if the tumor would have come in here, the next port of call for this tumor would be actually going down up to the hyoid bone along the submandibular gland. But that's not happened in this case. So it's pretty much restricted at this level at the edge of the mylohyoid shell.
So it is very, very important to identify where is the posterior location of the lesion, because you want to know, you are looking out for signs of inoperability in this. So when Sir said, is it coming through the submental space, you want to know whether it's involving the hyoid. As it's going posteriorly, you want to know whether it is coming onto the larynx. So is this lesion coming onto the hyoid? Is it coming onto the vallicular? Are there any possibilities that you will not want to operate this lesion? So first, when you're looking at all these large tongue lesions, you need to evaluate clinically and radiologically for signs of inoperability, because they may be futile surgeries. You might resect large lesions, but the patients tend to come back more often than not. So please be very careful, evaluate very critically whether this patient should undergo surgery.
Karthik, I want to thank you. Very, very well described.
Thank you so much, sir, for inviting me.
I hope to get you for more sessions where MRI is very important. Parotid is one, and parapharyngeal tumors is another. And I think Prathamesh will want you for some of the skull-based lesions.
Yes, sir. The paranasal sinus and skull.
Yeah. So I think we will need to get you involved more into these educational sessions. Thank you very much, Karthik. Thanks a lot.
Thank you so much.
Thanks, Prathamesh. Shall we call it a day?
Yes, sir. Thank you very much.
Thank
it was
you.
Very nice discussion.
Thank you. Thank you. Good night.
But once again, I want to tell all the postgraduates to please learn to unmute your mic and speak up. You must participate more actively. Yes, Prathamesh?
Yes, sir. I think maybe, we can sound out a few residents, those who are exam going, because they're going to benefit from participation in the discussion. We can go on asking questions, but unless we get a reciprocation, we won't understand whether we are benefiting them.
Yeah, Anju has actually told some of the third year students, but I think third and second year students should both get more active into it.
Yes, sir.
Thank you.
Thank you,
Thank
sir.
very much.
Good night.
Good night.
बंद कर दिया।